Thanks, Jamie. Good afternoon, everyone. So this afternoon, I'll be talking about Coxiella burnetii. It's quite an interesting organism, and I didn't know much about it before I did this talk. It was discovered more than 90 years ago, but due to its peculiar characteristics, there's still not a lot known about it, but we'll go through what we do know so far in this talk. So this is my presentation outline. I'll be talking about the microbiology, the history, epidemiology, pathophysiology, risk factors, clinical presentation, diagnosis, and then briefly on treatment and prevention of Coxiella. So starting off with the microbiology of Coxiella burnetii, just an overview of the phylogeny of the organism itself. It's quite closely related to the rickettsial group of organisms, particularly Rickettsiella, Garelli, and Legionella pneumophilia. So initially in 1937, when it was discovered, it was named Rickettsia burnetii and classified under the order Rickettsialis. In 1948, it was classified within a new genus as a new species, Coxiella burnetii, in honor of its discoverers, Dr. Cox and Dr. Burnett, under still the Rickettsialis order. And then in 1990, due to advances in molecular phylogenetics, it was then reclassified under the order Legionellales, under the family Coxiellacea, and became its own species, Coxiella burnetii. The image on the right is just an electron microscope image of the pleomorphic Coccobacillus structure of these Coxiella burnetii organisms. It is a strictly intracellular bacteria, so it's not visualized on routine microscopy. So this is an electron microscope image that just illustrates its structure quite nicely. With regards to why it was classified initially under the Rickettsialis order, we'll chat a bit about that when we talk about the history of its discovery. So it's a zoonotic bacterium. What do we mean by zoonotic bacterium? According to the WHO, it's any disease that's naturally transmissible from vertebrate animals to humans or vice versa. So there is this concept of priority zoonotic diseases, which is different for each of the countries across the globe. And the reason why there is this list of priority zoonotic diseases is that these diseases can cause quite significant illness amongst poor livestock workers in developing countries, and to date have caused up to 3 billion illnesses amongst these workers, as well as 2.7 million human deaths annually. So each country has their own priority list, and in South Africa, under bacterial, Coxiella burnetii falls under one of our priority zoonotic diseases. These diseases have the significant potential to affect human health locally and to spread globally. Like I said, it is an obligate intracellular microorganism. It proliferates within the phagolysosome environment of host cells, and we'll see that a bit later when we discuss the pathophysiology of Coxiella. Like I said, it's a pleomorphic gram-negative Coccobacillus, and it's about 0.3 to 1 micrometers long. Interestingly, it's a group B bioterrorism agent, and according to the CDC, it's been classified as group B because it's part of the group of agents that are the second highest priority agents. And the reason why it's a group B agent is that it's moderately easy to disseminate. It has moderate morbidity rates, but lower mortality rates compared to category A bioterrorism agents. And the consequence of that is that it requires specific enhancement of diagnostic capacity and enhanced disease surveillance. So interestingly, I was quite taken about this bioterrorist angle, and initially was first described as being used as a weapon of bioterrorism in the US, and then subsequently by the Soviet Union and Russia. But due to sanctions that were imposed in the 1940s and 1950s, it was strictly banned from being used and reproduced as a weapon of bioterrorism. So this was taken from a paper by Madarigia, and they just illustrated, just to give you an idea of the morbidity that's associated with use as a weapon. If you were to take 50 kilograms of Coxiella burnetii and release it over a 2-kilometer radius with wind that was directed to a densely populated city of 500,000 inhabitants, it would spread to about 20 kilometers apart from where it was released, and it would result in 150 deaths, 125,000 acutely ill, and 9,000 chronically ill people, with an uncertain number of psychiatric casualties. So it's really quite a phenomenal achievement for this organism. And so has been classified as this category B bioterrorist weapon. In terms of the history of Coxiella burnetii, this paper has been cited in almost every literature review and any case series about Coxiella burnetii. So this was from Dr. Edward Derrick in 1935, and he described a number of cases of fever among meat workers in Brisbane in Australia. So he actually noted that there were these peculiar patterns of infections amongst these meat workers that actually started in 1933. And until he had come across it in 1935, there were actually 20 cases in total that had similar patterns. He reported on 8 in this paper that he published in 1935. And he spoke about patients who presented with fever of 7 to 24 days with other features, especially of headache. This is taken directly from his paper, where he says the possibility of Q fever is to be borne in mind in the presence of a high fever of acute onset, accompanied by a severe headache and a comparatively slow pulse rate and no other obvious localizing symptoms. Now, they had entertained other differential diagnoses, including other zoonotic infections, but because blood cultures and agglutination tests done at the time had not yielded anything, they were unsure about what the etiology of this fever was. And so they had designated it Q fever or query fever, which is where the name had come about, until they found a more plausible explanation for what the cause was in terms of investigating an etiology. So because they couldn't find anything on culture, they initially thought that it was a virus. So he postulated that the abundance of the virus of Q fever in the blood and the ease with which the disease may be transmitted by injection render it likely that some blood-sucking vector is responsible for the natural transmission and that there's a reservoir of infection in some animal. So this was the first postulated theory that there could be mammalian reservoirs for Coxiella burnetii. So because he couldn't find anything on culture and agglutination tests, he had sent specimens to his colleague, Dr. F.M. Burnett, who was at the time in Melbourne, and he had transferred these guinea pigs that were infected with Q fever to Dr. Burnett, who then transferred the infection over to mice, where he discovered rickettsial bodies in their spleen, and hence why it was classified under the order Rickettsialis in the early 1930s. And then a few years later, he worked with Dr. Cox, who was able to culture it from embryonated eggs, and hence the name Coxiella burnetii in honor of the two of them as the etiological agent of Q fever. With regards to the epidemiology of Coxiella burnetii, it's a worldwide zoonosis, so it's endemic in almost every country except for New Zealand and Antarctica. The incidence is underestimated due to a number of factors. One is that there's a diverse presentation in both mammals and humans. So when we look at the clinical presentation, we'll see that almost any organ system can be affected by Coxiella. So it's quite difficult to think of Coxiella as your number one differentials when patients present with such a broad array of symptoms and signs. The second thing is that almost 60% of human infections are actually asymptomatic. So a lot of people don't even know that they have acute Q fever. And so obviously that affects the incidence and prevalence rates that are reported. The third thing is that testing is not routinely available or may not be requested. And the last thing is that it's not a notifiable disease in a lot of the countries. To date, I think it's only been made mandatory to be reported in America since 1999 as a notifiable condition. So why had there been this renewed interest in Coxiella recently? So the largest known human outbreak had occurred between 2007 and 2010 in the Netherlands, where there were more than 3,500 cases of Coxiella affecting humans, and that was from infected dairy goat herds. And so since then, there's just been this renewed interest in studying the prevalence rates of Coxiella across the globe. So this is actually taken from the One Health Systematic Review, which looked at the prevalence of Coxiella in both mammals as well as humans in Africa. Just to highlight that the first documented case of Coxiella in Africa was actually in 1947. So I've just highlighted here the cases of the number of positive cases in humans that were confirmed on serology in the various regions in Africa. So this is in Northern Africa, so particularly Egypt, Tunisia. This is in Western Africa, so Cote d'Ivoire, Burkina Faso, Niger. And then this is Mid-Africa and Cameroon, and then Eastern Africa in Tanzania. And then this is in Southern Africa. And interestingly, although there was suspicion for human pneumonia, unfortunately with serology, there wasn't any confirmed cases. Just to highlight and just to give an example, with regards to the seroprevalence rates in Africa, when we look at places like Egypt, for example, the seroprevalence rates in mammals from sheep to goats to cattle range from 33 to 13%, and in humans was 16%. And in areas like Chad, animals like the camels almost had an 80% positive seroprevalence rate, 13% in goats, 11% in sheep, 4% in cattle, and 1% in humans. This is taken from a paper published here in South Africa, where they surveyed South African abattoir workers. This is just, the table on the left is just looking at their various demographics, and they actually surveyed 382 workers from 16 facilities and found that the seroprevalence rate was actually 30%, with a range from 8 to 62% at facility level. So it's definitely there. We just need to look hard for it in the right clinical context. So looking at the pathophysiology of Coxiella burnetii, the image on the left is just to illustrate the various modes of transmission. So I'll start here on the right with the bioterrorism mode of transmission and work clockwise. So obviously we have spoken about aerosolization. So if there's release of massive amounts of Coxiella in a very densely populated area, that would cause an abrupt onset of symptoms through inhalation of these spores. There's also been postulation about contaminated mail, similarly to what happened with the anthrax outbreak in the US, then contaminated food or water. Sexual transmission has been described, but it's very rare. There's also transmission described through blood transfusions. Ticks, also again, very rare. Exposure to infected products of conception. So when we look at the mammalians that are affected, it's actually a very broad and diverse range of animals that can be affected. It ranges from domestic animals, birds, arthropods, ticks, like I just mentioned, and rodents. And often these patients, the mammals are asymptomatic, but the one clue is that you may have a high rate of miscarriages and stillbirths amongst these mammalian reservoirs. The other thing is that there is shedding of Coxiella in various bodily fluids that include urine, feces, milk, and especially products of conception. And in a slide or two, I'll just show you a table that illustrates how long shedding occurs for and how long those spores actually last in the environment. There's also occupational exposure. So this includes people who work in farms, abattoir workers, meat packers, lab workers that are in contact with livestock, but also lab workers who deal with processing of specimens that are suspected of being Coxiella. Contaminated hay is actually interesting. So this was described first with military personnel who would use contaminated hay stables that were previously used or occupied by infected sheep. and that was a possible risk for them for contracting the disease. And then contaminated dust. And this is from the spores that have been in the dust that have then been subsequently aerosolized, either due to construction or demolition in particular areas. So this is how we get, so these are the modes of transmission. So this is how we get exposed to Coxiella. So what actually happens from a molecular level for us in the human to propagate infection? So here, this is just a very simple diagram that illustrates the various forms of Coxiella from a molecular point of view. So you have the human that inhales the spore or inhales the organism. And what happens then is that the structure of the organism that we inhale is actually what we call the small cell variant. So when we look at the structure of the Coxiella organism, you have small cell variant, large cell variants, that's what LCV stands for, and then you have the spore form. So the small cell, large cell, and the spore both have similar structures in terms of an inner membrane, an outer membrane, and then a peptidoglycan layer in between. So the small cell variant is the variant that we inhale. It binds then to the host cell via ankyrin or spectrin binding proteins, and then is taken up by the cell. The target cell here is usually the macrophage, and because it's inhaled, the specific macrophage that is affected the most is the alveolar macrophage. So it's engulfed into the cell, it forms a phagosome. From there, it joins with the lysosome to form a phagolysosome. Once within this phagolysosome, there's an acidic environment that is present here. And this acidic environment actually facilitates the replication process of the Coxiella organism. So it activates certain proteins, certain transport mechanisms, and allows it to form this large cell variant, which is a more stable form. And from this large cell variant, you have transverse binary fission, so you have production of more large cell variants, and you have production of spores. So from the small cell variant, you have the large cell variant. The large cell variant forms more large cell variants, or it can form these spores, and the spores are exocytosed from the cell and enter the circulation. So how Coxiella moves from the macrophage to the various organ systems, we're actually not sure. There have been various postulated mechanisms. So either that it moves with the macrophage to those specific organ sites, or it's through this free blood-borne forms that move through the blood and then infect the various organisms. The various organ systems. So that aspect of how it actually gets from the macrophage to the specific organ is not really clearly described. So in terms of clearance of this organism, you need cell-mediated immunity to clear this agent. And it's normally a Th1-driven response. So you have interferon gamma, which induces an alkaline environment in this phagolysosome. And so when the pH increases, this actually halts the replication process within this phagolysosome, and that prevents bacterial replication. There's also stimulation of tumor necrosis factor alpha, and that causes apoptosis of these macrophages. So failure of this Th1-driven response to clear the organism is what results in chronic infection. This is just a nice, I thought, summary of just the various modes of transmission, the various life cycles of Coxiella in different populations. So you have the sylvatic cycle, which involves the ticks, wild birds and animals, predators, domestic cycle, which is involving the domestic ruminants, and then you have spillover into the environment. And how it gets to the human is either direct or indirect contact through contaminated placenta and abortion materials, contaminated hides and wool, contaminated urine, manure, and body secretions. There's ingestion of contaminated milk, contaminated dairy products, contaminated meat products, and then inhalation, so contaminated aerosols, soil, or desiccated biological waste. And then these are from human to human, so blood transfusions, respiratory nosocomial spread, infected pregnant women, sexual transmission, and bioterrorist mode. So this is just to keep in mind that there seem to be quite a few environmental reservoirs that this will be important to consider when we discuss prevention strategies for Coxiella burnetii. So this looks at shedding patterns of Coxiella burnetii in ruminants. So just to highlight that these are the various bodily secretions. This is the species. So for example, in cows, you can have shedding of Coxiella for up to 14 days. In milk, you can have it up to 13 months. Sheep, in the vaginal mucosa, can be up to 3 months. Feces, 5 months. Milk, 4 months. Goat, again, vaginal secretions, 95 days. Feces, 5 months. Milk, 3 months. So you can have quite prolonged periods of shedding from these various domestic animals. And then looking at the survival period, once they're in the environment or on various sources, you can see dried milk can be up to 60 days, soil up to 150 days, wool up to 10 months, ripened cheese up to 8 months. So really quite stable and viable in the environment for a long period of time. When we look at the risk factors for Coxiella burnetii, it's been highlighted, these have been the main risk factors. It obviously is related to the modes of transmission. So men have been found to be at higher risk, and this is mainly related to the occupations that are taken up. So mainly farmers, veterinary workers, abattoir workers, people who spend time in ranches or livestock facilities. And just to highlight here, it's not just people who actually stay within these ranches or livestock facilities. Untreated sewage or untreated products with animal washings, dung, discarded products of conception from farms that then spill over or wash down to inhabitants, maybe 2, 3, 4, 5, up to 10 kilometers away from these farms, can also be at risk of contracting Coxiella. Ingestion of contaminated milk, laboratory exposure to Coxiella, blood transfusions. There have been documented cases during autopsies, sexual transmission, like we had spoken about, but that's quite rare, pregnancy, immunosuppressed patients, and patients with cardiac valve defects and implants are also at risk for Coxiella. There's also been a seasonal risk where the highest risk seems to be related to spring and summer times, and that may be related to livestock birthing or the manure spreading that occurs during those particular seasons. The last 3 risk factors here, pregnancy, immunosuppressed patients, and patients with cardiac valve defects and implants, are actually specific risk factors for chronic Coxiella infection. So looking at clinical presentation, this was just a nice illustration, just giving a brief, like a nice overview of the various clinical syndromes that can be caused by Coxiella. So you have inhalation of the contaminated aerosols, like we had described previously, which can either be the small cell variants or the spores. Interestingly, you don't need a very high inoculum. So even 1 microorganism, so they describe 1 to 10 being low enough to cause disease. So really very highly infectious. Even if you just inhale 1 organism, you can present in a susceptible host, you can present with features of Q fever. So you have acute Q fever. 60% of cases, the majority, like I had mentioned before, are actually asymptomatic, so have no idea they've had Q fever. 40% of cases are symptomatic, and of those, about 95 to 98% of cases are actually mild. And in the next slide, I'll describe what this actually means. And then of these 40%, 2 to 5% have severe or they require hospitalization, and they usually present with either pneumonia, hepatitis, myocarditis, or neurological symptoms. Then 1 to 5% of patients who have acute Q fever develop chronic fever, and this is with predisposing factors. So if they're immunosuppressed or pregnant, they have heart valve lesions or vascular abnormalities. And when it comes to the chronic Q fever syndromes, it's mainly endocarditis. We do know it's one of the causes of culture negative endocarditis. And then you have other syndromes associated with chronic Q fever. So that's osteomyelitis, chronic hepatitis, interstitial lung disease, repeated abortions, and chronic fatigue syndrome. So this was taken, I took this because I thought it was a nice overview, just compartmentalizing the clinical syndromes of acute Q fever. And this is taken from a paper by Palmella. And they looked at the clinical syndromes of patients that presented to their facility that were diagnosed with acute Q fever. So you have isolated febrile syndromes. So this is where the patients present with this flu-like illness. They have nausea, fatigue, severe headache, myalgia, chills, sweating, and actually have profound weight loss of 6 to 12 kilograms. So that usually, those symptoms usually occur for about 1 to 10 days. Usually by day 10, the symptoms start to disappear, but the malaise may persist for a number of months. Then you have hepatic involvement. So patients can present with a transaminitis, cholecystitis, very rarely present with acute liver failure. And what's interesting about these patients is that once they're biopsied, there's a particular finding on biopsy noted as ring donuts on histology of these livers that have been infected by Coxiella. And that's where you have this dense fibrin ring that's surrounded by a central lipid vacuole. You have pulmonary involvement, which is actually the most common severe presentation of acute Coxiella fever. Patients may present with even what's known as present with an atypical pneumonia, a rapidly progressive pneumonia, and sometimes it's just found incidentally with X-ray features suggestive of a pneumonia. The radiological features are quite variable, so there's not specific characteristics on X-ray that will point you to saying that this is definitely Coxiella. So it's all quite non-specific, but in the right patient with the right exposure history, it's one of the most common presentations of acute Q fever. You have myocarditis, also another syndrome of acute Q fever, and in some of the case reports has actually been documented as a missed cause of death in patients who present with acute Q fever. And then neurological involvement. So just like Dr. Edward Derrick had described in 1935, patients present with a severe headache, but about 0.2 to 1.3% of cases actually present with an aseptic meningitis or an encephalitis. Other less common manifestations of the CNS involve behavioral disturbances, cerebellar symptoms, cranial nerve symptoms, extrapyramidal symptoms, and GBS-like syndromes. And so it can be anything, and it can be quite varied. So just looking at the acute Q fever syndromes, you can see that almost every system is affected and it's really quite non-specific. And so essentially you could be thinking about Coxiella for all your patients that present with these various clinical syndromes. Looking at chronic Q fever, so I know that it's a bit of a busy slide, but I just wanted to highlight two things here. So this looked at the Dutch consensus guideline on chronic Q fever diagnostics. So you have proven, probable, or possible chronic Q fever. And I just want to focus on the proven chronic Q fever. So there's three things that you need. One is that, so there's actually two things that you need. One is that you need positive Coxiella burnetii PCR of blood or tissue, or you need suggestive serology to say that this is possibly chronic Q fever. In addition to that, you do need to have evidence of organ involvement, so either in the form of endocarditis, large vessel infection, or prosthetic infection. The probable and possible chronic Q fever, there's various criteria that you need to meet for that, but the proven one is what's important. So you need suggestive serology or confirmation of Coxiella with the right clinical presentation in terms of organ involvement. And that includes endocarditis, vascular infection, prosthetic joint infection, or osteoarticular infection without prosthesis. This is just to illustrate the various criteria that have been used to diagnose chronic Q fever vascular infection and chronic Q fever endocarditis. The other chronic Q fever presentations include Q fever in the immunocompromised host, and usually these patients present with fatal interstitial pneumonia, endocarditis. It's also been associated with an increased risk of non-benign lesions, mainly non-Hodgkin's lymphoma. There have also been hematological manifestations in the form of bone marrow necrosis, HLH, as well as splenic rupture. Q fever in pregnancy is quite a well-documented phenomenon. Coxiella loves to replicate in the trophoblast, if infection occurs in the first trimester, it results in miscarriage. If it occurs in the second and third trimester, it can result in low birth weight and premature delivery. In terms of post-Q fever fatigue syndrome, it is a recognized syndrome post-acute Q fever, and it's been defined by the International Working Group as the presence of fatigue, myalgia, arthralgia, night sweats, changes in mood and sleep patterns, which persist after a year following symptomatic acute Q fever with high antibody titers, but no features of chronic Q fever in terms of actual organ involvement. It occurs in about 20% of patients who develop acute infection and is thought to be related to the cytokine dysfunction and immunomodulation, especially through interleukin-6 from persistence of Coxiella burnetii. In terms of diagnostics, there's various ways or methods for diagnosing Coxiella. So first is, what's important is that with any of this diagnostic procedures, it's important that this needs to happen in a BSL-3 lab because of the risk of aerosolization and infecting laboratory staff. So you have culture-based techniques where you can use embryonated hen yolk sacs, conventional cell cultures, and laboratory animals like guinea pigs and mice. It's quite a laborious task and very time-consuming. And so it's often reserved for research facilities, so it's not done routinely in your conventional laboratories. In terms of tissue that's sent, you can do both for formalin-fixed as well as paraffin-embedded tissue. You can do immunoperoxidase staining with ELISA methods or monoclonal antibodies. You can also directly visualize Coxiella in infected tissues by this Gamesa staining. And then histological specimens may also show granulomas, like I described, that donut ring granulomas with patients who present with acute Q fever hepatitis, and then nucleic acid detection, which is the PCR-based techniques, which can either be applied to whole blood or to tissue. What's commonly used, though, is serology. And the serology, when I first read about it, I got quite confused about it because they spoke a lot about phase 1 and phase 2, and it was quite difficult for me to try and understand what it means, but I hope I can make sense of this for you during this talk. So the serology, when we talk about phase 1 and phase 2 antibodies, actually relates to the structure of the microorganism when it undergoes the laboratory process, when it undergoes laboratory processing. So I'm going to try and relate the phase 1 and phase 2 structures to the original molecular pathogenesis so that you're able to understand why phase 1 is suggestive more of chronic infection, whereas phase 2 is suggestive of acute infection. So like I had said before, and I'm just going to reference this picture, you have these various forms, the small cell, large cell, and the spores, and you have an inner outer membrane and a peptidoglycan layer. So when you look at the LPS structure of phase 1 is almost described as the microorganism when it finds itself within the host. So that's what you find isolated within the cell. So if you were to look at this and kind of try and picture this with the molecular pathogenesis, you would see that it's almost akin to this large cell variant structure. So the small cell is what you inhale. It's what's endocytosed. It then fuses with, it's taken up by the phagosome, fuses with the lysosome, and then within this phagolysosome, you have this large cell variant. And this is the one that actually replicates, and you form more large cell variants or the endospores. And so this is, you can almost think of it as being the one that causes infection. It's more infectious because that's the spore form. It is the more virulent phase, and it's because it persists on in the cell, it's more indicative of chronic Q fever. So when we refer to phase 1 antibodies, we're actually looking at features suggestive of chronic infection, whereas phase 2 is more related to in the lab when they process these specimens in cultures, after several passages in cell cultures, this lipopolysaccharide layer actually loses a lot of its antigens and becomes less complex. And it almost is described as this energy-saving mode to allow the microorganism to improve its replication. So it's almost, if you look at this diagram, like the small cell variant that's initially taken up by the cell, and once it's within the right environment, is then transformed into this large cell variant. So it's less complex, it's less virulent, it's not contagious, and it's more suggestive of acute Q fever. So when we refer to antibodies against phase 1, we talk about chronic infection. And when we look at antibodies against phase 2, we're talking about acute infection. So this is just a graphical representation of the antibody production. Usually it starts at about 2 to 3 weeks, and after the occurrence of infection, and it can persist for months, sometimes years to lifelong. And you can see here you have phase 1 IgG and phase 1 IgM, and the same applies to phase 2. You have both IgG and IgM. The issue with the IgM is that it's less specific. It tends to go down, whether it's directed to phase 1 or phase 2, more or less a similar pattern, but it can persist for a long time. What we are more concerned about is what we focus more on is the IgG titers. So we look at specific cutoff points depending on the clinical syndrome, and we look for any rise in the titers on subsequent samples that are taken like 3 to 6 weeks apart. So there's a few things just to keep in mind with regards to when you're interpreting serology. The first thing is that the serology can persist, like I said, for a very long time. And so with patients who've been previously exposed to Coxiella, you must bear that in mind when you're trying to interpret whether these patients currently have any features suggestive of chronic Q fever. So you must keep previous exposure in mind and patients who already have baseline presence of antibodies. The second thing is that it can cross-react with other infections. So it can cross-react with Legionella, Bartonella, and Pseudomonas. But the literature has suggested that the antibody titers are not as high as they would be if it was actual Q fever. So if it was any of the other infections, the antibody titers may be a bit lower compared to what you would actually see with Coxiella. The third thing is that there is the presence at the same time of multiple transient autoantibodies that may be present. So you may have the presence of a positive rheumatoid factor, positive Coombs test, positive ANA, and it's just something to bear in mind when you're interpreting this test. Now, serology is not just phase 1, phase 2 antibodies. There are various methods that you can do to so there's various serological methods, and the table I think in a slide or two will just illustrate the differences. So the first is that you have the indirect immunofluorescent assay. So that's the IFA, which is most commonly done. That's what we do as well. There's also an ELISA-based method, which is qualitative, not quantitative. There's agglutination tests, complement fixation assays, and Western blot tests as well. So it's not just, oh, I'm doing serology. Remember, there are various ways in which you can do serology. And when you're comparing patients on follow-up, you must make sure that you're using the same serological method that you used the first time. This is taken from the CDC, and this is from the Q Fever Working Group. And this is from 2013. And just to highlight acute and chronic Q fever, when you look at laboratory confirmed cases, you need for acute Q fever, you need a 4-fold change in IgG antibody titer to Coxiella burnetii. And this, like I said, is so these are antibodies directed against phase 2. And you need a 4-fold increase in the antibody titer. And usually samples are taken about 3 to 6 weeks apart. With chronic Q fever, it's more the antibody titer. So we look at the cutoff, and they use a antibody titer of more than 1:800 to phase 1 antigen by IFA as being suggestive of chronic Q fever. This was a nice table taken from an Australian paper looking at the time of onset of symptoms and then the antibody titers according to those times. So it's quite, I mean, it's quite a complicated table here, and you have to look at each of the serological methods on its own. But essentially what I wanted to just highlight is that you've got enzyme immunoassays, complement fixation tests, and IFAs, which is the indirect immunofluorescent assays. And so these are all different methods, and you can see that they all don't have the same cutoff points. So when you're interpreting or doing monitoring for these patients, you must make sure that the serological method that you use initially is what you're actually using for follow-up. And then in terms of treatment and prevention, this is again taken from the same working group and the CDC. And when we look at acute Q fever, we advocate the use of doxycycline, so 100 milligrams twice daily for 14 days. And then for pregnant women, because you can't use doxy, you'd use Bactrim throughout the duration of the pregnancy. It's quite interesting because even within the CDC document, there is actually no consensus as to who do you treat with acute Q fever. So some people say that treat all cases, regardless of how they present. Others have advocated that only patients who are hospitalized or have severe manifestations should be treated. And other people have suggested that patients who have risk factors for progression to chronic Q fever should be treated. So there's no real, consensus on who to treat, because some people will choose to treat certain risk groups over others. And that's because a lot of patients, even without treatment, will have self-resolving infection within 2 to 3 weeks. With regards to chronic Q fever, you have endocarditis or vascular infection, where it's advocated to use dual therapy in the form of doxycycline and hydroxychloroquine. The duration of treatment is very long, so it's more than 18 months and can go up to 3 years. In terms of non-cardiac organ disease, same applies. And postpartum patients with serological profiles consistent with chronic Q fever, again, will be treated with dual therapy for up to a year, and can go up depending on their serological response. The rationale for the use of hydroxychloroquine is actually for synergistic action. So hydroxychloroquine has been shown to increase the pH in the phageal lysosome within macrophages, which halts bacterial replication, and that's shown to assist bacterial killing in addition to doxycycline. So that's why they advocate for the use of dual therapy with chronic Q fever. In terms of how long you actually treat them for, these recommendations of 1 year, 18 months is a bare minimum. The CDC has recommended that we do serial serologies to decide on when to actually stop treatment. So on subsequent serologies, so I'll start off with acute Q fever. So if you've got acute Q fever with no risk factors for progression to chronic Q fever, they recommend repeating serology in about 6 months to make sure that there's a fourfold reduction in the antibody titers. If you have acute Q fever, but you have risk factors for progression to chronic Q fever, they actually recommend repeat serologies at 3, 6, 12, 18, and 24 months. So that's the case of acute Q fever. With regards to chronic Q fever, they recommend checking serology once a month for the first 6 months, and then every 3 months to assess how long you're going to treat for. So if you find that there's a fourfold reduction in antibody titers after 18 months or so of treatment, then they suggest to stop antibiotic treatment after this prolonged period of time, but to do serologies twice a year for a minimum of up to 5 years post-stopping treatment. So these patients, although you would treat for a long time, you would still need to follow up for quite a significant amount of time afterwards. With regards to prevention, vaccination is advocated for at-risk people. So this is mainly people who have occupational risk. So arbiter workers, meat packers, farmers, veterinary workers, and laboratory workers. There's currently one vaccine that has been licensed to be used in Australia. It hasn't been really available in any of the other countries to be used. It's quite a, it's not the best vaccination at that, because there is a warning that patients who have had previous Coxiella infection need, if you give those people the vaccination, they tend to have a more severe reaction to the vaccine. So often they recommend doing a test strip before actually giving vaccination for these people, and that may become problematic if you're trying to do large-scale vaccination programs globally, because it's not. I mean, it may cause more harm in patients who've already had Coxiella infection previously. It does confer lifelong immunity, though. So for patients who don't react, it may be something plausible. Vaccination of animals is not, again, not a practical solution. So if you remember all the sylvatic, domestic, predator life cycles, there's too many animal reservoirs and possible modes of transmission from animals. And so that also hasn't really been advocated in terms of a preventative measure. There are some groups that advocate vaccination of sheep, goats, and cattle in local farming communities, but large-scale vaccination programs may not be practical in that sense. And then risk reduction practices. So this is the most important. So in terms of hospitalized patients who have acute Q fever, who will undergo aerosolization procedures, so either bronchs or some other respiratory procedure, appropriate PPE is required. If you are delivering the baby of an infected mother, that also requires appropriate PPE. There's recommendation of pasteurization of milk, and most importantly, safe disposal of aborted material from local farming communities, and to make sure that the areas in which this is done within those facilities are properly disinfected. The other things that have been described in the literature is control of ectoparasites on cattle, goats, and sheep. But again, that may not be a practical thing. And they've also suggested that blood donors from areas that are experiencing a Coxiella outbreak shouldn't be allowed to donate blood during that period or a month or two after the outbreak has stopped. So really, in terms of prevention, the vaccination is there, but again, is not, from a practical point of view, the most, can't really be applied on a large scale. And then risk reduction practices are most important in terms of prevention of Coxiella. Yeah, and that's it.
Cool. Thanks so much, Sharon. A really, really tough topic in some ways, which is why it's a good topic to talk about. But as you said, the diagnosis is a mess with this pathogen. Really, in some ways, very, very complex. And I mean, I think, as you said, the second one, and it's often not considered early on in the first week or so of of illness, or the first 2 weeks, when this is most likely to be of use in the first of the paired samples. So it's really, 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 really challenging. And you've done a great job. Just looking at some of the questions that are on the chat and on WhatsApp. There's a question from Lauren about testing for it in a patient who has miscarriages.
So it's interesting. I think that I don't think it should be routinely done for patients who have recurrent miscarriages. I think in the right context, if they have the right exposure history, and their otherwise secondary workup has come back negative, then I would consider testing it. But I think that's why the CDC and even the Dutch consensus guidelines have made it, have said that even though because remember, a lot of people may have had Coxiella previously, which has nothing to do with their current issue. And so you have to have the right serological diagnosis with the correct, or to have the right organ involvement together to make that diagnosis. So I wouldn't say that I would routinely test for it. I think if the patient has appropriate risk factors in terms of exposure history, I would consider testing for it, but I don't think I would do it routinely.
Yeah, I guess the issue is the recurrence of it, you know, so there should be a one-off thing, right? In this case, is if you're acquiring Coxiella now, acute Coxiella, you know, acute Q fever, and that may in some cases lead to abortion, right? But I don't think it should happen the second time around, right?
Yeah.
Or does it?
Yeah. No, it doesn't. So in terms of abortions related to Coxiella from a chronic point of view, from what I've read, it's just once off. So it's not a recurrent, it's not a cause of recurrent miscarriages.
Okay. And then Eunice has suggested it would be interesting to hear the experience of the audience, which I agree with. Has anyone in the audience made the diagnosis before? And just stick up your hand and I'll unmute you. In the meantime, I can say, I mean, Eunice, from our side, we've had 1 or 2 endocarditises which have been proven, but I guess by serology, but nonetheless proven. I think that's it in terms of our exposure, but I suppose if you're in an environment where people have a lot more exposure to livestock, or, you know, such as, you know, farmers, you know, abattoir workers, that's the thing you might see slightly more, but I don't think it's a common diagnosis. Certainly, even in endocarditis among those ones, you know, of the culture negatives in South Africa, it's quite uncommon. It's more common in different countries, I think, but not so much us. Don't think anyone else in the audience has made a diagnosis by the look of it. Yeah, interesting. Okay. And when would you suggest, if Sharon, if you were in charge of upping the diagnosis of Coxiella because you think it's an important issue, what would you suggest to people? When would you suggest they test? Because clearly a lot of the acute illness is self-limiting anyway, and most of it will get better even without treatment. So where do you think the value is, do you think?
I think the value is in patients who, from what I've read, is from patients who have predisposing risk factors to progress to chronic Q fever, because they will then present with, you know, like endocarditis, osteomyelitis, septic arthritis, joint infections and things. So I think patients who, you know, immunosuppressed patients, pregnant patients, patients who have pre-existing valve conditions or vascular abnormalities would be the patients who, following acute infection, I would probably want to follow up and test for, because the morbidity associated with that is higher. So yes, a lot of patients do, the majority of patients do clear it acutely, but there's those specific subset of patients who are more likely to progress to chronic Q fever syndrome. So those would be the patients I think I would probably want to test for. And if they presented with any of those symptoms and have, you know, the right risk factors, those would be the ones that I would test for. I don't think advocating testing for everybody is practical, because it's like when you look at the acute Q fever presentations, they're so varied and so diverse. It would mean that we end up testing everyone we see in hospital, which is not practical. So yeah, I think those would be the people that I would be interested in testing and following up.
And then a question about endocarditis treatment. So the duration, I know you said minimum 18 months.
Yeah.
I believe it's also sort of and until the phase 1 antibodies are low enough.
Yes. Yeah. So minimum of 18 months can be up to 3 years, or you just keep going until the antibody titers reduce by 4-fold and the IgM is completely undetectable. And then even after that, you would still have to monitor them with serology up to a minimum of 5 years. So it's quite a long duration of treatment and follow-up for these patients. So yeah, minimum 18 months, but can go up to 3 years or longer depending on the serological response.
Yeah, I was going to say, I mean, in some patients indefinite. So some never stop, sort of lifelong treatment, which is astonishing actually when you think of it. And then last question just come through. They're asking about the mechanism of hydroxychloroquine. I think you may have mentioned it. Sorry, but it is a
Yeah,
question.
so how it works is that it actually increases the pH. I'm not sure how it does that from a molecular point of view, but it's been said that it increases the pH of the phagolysosome. So remember that the Coxiella thrives in the acidic pH within the phagolysosome. So once the pH is increased within that phagolysosome, it halts bacterial replication. So that's why they've advocated for dual therapy with hydroxychloroquine, is to try and reduce replication from that phagolysosome point of view within the macrophage. So that's why they've advocated for the use specifically of hydroxychloroquine with doxycycline for these chronic Q fever syndromes.
Cool.
Yeah.
All right. I think we're going to end there, but thank you so much, Sharon. That's a fantastic overview. Very, very difficult topic, as you said, and it's something that keeps coming up, but it's astonishingly hard to diagnose in many cases or interpret. I think I've probably phoned once every week or two with a question about how to interpret the serology. So it's a bit of a nightmare. But thank you very much.